Fetal circulation is different from adult circulation. In fetal circulation, placenta does the oxygenation, while in adult circulation, it is the lungs which does the oxygenation. And fetal circulation can be called as a shunt dependent circulation because there are intracardiac and extracardiac shunts. Most of the blood coming from the umbilical vein, which is having a higher oxygen saturation, is shunted through the ductus venosus into the inferior vena cava without participating in the hepatic region. And there is streaming of blood within the inferior vena cava so that the desaturated blood and the saturated blood goes in almost two separate streams within the inferior vena cava. The eustachian valve at the opening of the inferior vena cava into the right atrium directs the blood, more saturated blood, coming from the umbilical vein across the patent foraminal veil into the left atrium. From the left atrium, it reaches left ventricle and is pumped out into the aorta to reach the brain, so that brain gets more saturated blood than the inferior vena cava blood. Inferior vena cava blood is, on the other hand, streamed to the right ventricle and pulmonary artery, and then it will go down the ductus arteriosus. In fetus circulation, instead of saying left ventricular and right ventricular output, it is known as combined ventricular output. And 45% of the combined ventricular output goes to the placenta for oxygenation. Lungs receive only 8% because lungs are not functional in the fetus in terms of oxygenation. That is what happens in fetal circulation. Changes which occur after birth is known as transitional circulation. There is another shunt occurring in fetal circulation. Blood from inferior vena cava reaches the right ventricle and is pumped out into the pulmonary artery. Only a part of it reaches the lungs. Rest of it is shunted down the ductus arteriosus into the descending aorta, and lower limbs and lower part of the body gets less saturated blood. And a large part of it goes into the umbilical artery to the placenta for oxygenation. In fetal circulation, right ventricle is dominant, while in adult circulation, left ventricle is dominant. That is because there is pulmonary venous return and left ventricle gets enough blood to pump to the systemic circulation, which has a higher resistance compared to pulmonary circulation. So LV mass increases, RV mass regresses after birth. The three important shunts in fetal circulation gets obliterated after birth. Patent foraminal veil closes when left atrial pressure increases as pulmonary venous return increases from the functioning lung. Ductus venosus gets obliterated, and so does PDA, patent ductus arteriosus, also closes soon after birth. But there are certain conditions which are known as ductus dependent circulation. It could be ductus dependent pulmonary circulation, ductus dependent systemic circulation, or a combination of the two. This is a ductus dependent pulmonary circulation with pulmonary atresia VSD, tetralogy of Fallot equivalent, when PDA is useful for survival. Without a PDA, there will be no pulmonary blood flow. So that is a ductus dependent pulmonary circulation. The other way around, when there is aortic atresia, you will need PDA for systemic circulation. That is ductus dependent systemic circulation. Whenever there is a ductus dependent circulation, we want to prevent spontaneous closure of the PDA, which will cause rapid deterioration. what is done is that immediately prostaglandin infusion is given so that the ductus remains patent. And after that, sometimes a ductal stenting may be done, or an aortopulmonary anastomosis like modified blalotoxic shunt can be done to increase pulmonary blood flow in ductus dependent pulmonary circulations. And finally, intracardiac repair of tetralogy of Fallot has to be done for a definitive repair. Just as we have conditions in which ductus arteriosus has to be maintained patent, there are also conditions in which shunt across the interatrial septum has to be maintained. Typically, they are one is transposition of great arteries, second is total anomalous venous connection. In these two situations, a large atrial septal defect with adequate mixing is important for survival. Otherwise, the baby will not survive. A catheter is introduced, balloon catheter, and passed across the foramen veil, inflated and pulled down so that there is a partial tear of the interatrial septum, producing a good atrial septal defect, which will enable good mixing between the right atrial and left atrial blood in conditions like transposition of great arteries and total anomalous pulmonary venous connection. And after that, the systemic saturation will improve. Later on, the sick babies will improve and can be taken up for corrective surgery, either arterial switch operation for transposition of great arteries or correction rerouting of the pulmonary veins for total anomalous pulmonary venous drainage.